bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, the Holland Bloorview Children's Rehabilitation Hospital Foundation, the Children's Hospital Foundation of Saskatchewan, and Trillium Health Partners. We would also like to thank the following Keystone and program partners for their ongoing contributions that support all of CAFC's programs and activities. If you have any questions or comments for our panelists, please type them into the question box at any time during the presentation. You can also share your thoughts and questions on Twitter by tagging @CAFCTweets and using the hashtag CAFCPresents. All of our webinars are recorded and can be found on the CAFC Knowledge Exchange Network. Use the CAN to share these recordings with your colleagues or register an account and post comments, links, or other resources that you think will be of interest. And be sure to sign up for the CAFC Presents weekly email newsletter to stay up to date with upcoming webinars and our recorded webinar archive.
All right, hello everyone, and welcome to today's episode of CAFC Presents. I'm Doug Moyneur, the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. And today we're going to be talking about sharing data without sharing data. It's going to be an interesting discussion today, and I'm sure you can tell by the, as I'm sure you can tell by the intriguing title, and we're going to have some great presenters that are going to sort of explain exactly what they mean by that in a few minutes. But data in healthcare has been a topic at a number of our CAFC Presents sessions. We've had our colleagues from PolicyWise in Alberta talk about their SAGE and CYDL initiatives, which were linking data across different databases in different sectors and talking about the challenges there. We've had folks from our CPDSN network and our PERS folks are having a webinar coming up, and they've done webinars in the past, and all of that's available on the Knowledge Exchange Network if anyone wants to go back and check those out. And I strongly encourage you to do that, because there's so much going on in the world of data in healthcare. And so often when we have these data conversations, we inevitably end up in a discussion about the challenges that we face in sharing data outside your organization, sharing data across provincial boundaries, sharing data internationally, etc. So today we're going to have, we have in fact not one but two Ericks with us today to tell us a bit more about what they have done and some of the work they do that helps address some of these issues with sharing data in the healthcare environment, and how they bring value from that data to clinicians and administrators at all level of organizations. So we have with us Erick Moyneur and Erick Revel, who are both from StatLog Econometrics, both of them located in Montreal. Erick Moyneur comes with a background in math and economics, and Erick Revel comes to us with a background in finance and economics, so definitely not healthcare folks, but they've been working in the healthcare environment for a while, and I think this is going to be a really interesting and unique perspective on health data, since they don't come from that healthcare provider background. And in the audience today, we've got a really wide breadth of people who work with data, people from a number of data initiatives across Canada, and we also have folks who would come from that sort of end user group of clinicians and administrators that are looking to improve their services through using data. So we've got quite an interesting mix in the audience and quite an interesting perspective from our panelists. So please don't hesitate to type your questions in at any time during the presentation, and we'll certainly be getting to those at the end of the presentation. So it's my pleasure to hand the virtual podium over to Erick Moyneur and Erick Revel in Montreal at StatLog Econometrics. Over to you guys.
Hello, everyone. My name is Erick Moyneur, and I'm here with Erick Revel, and we've been working with healthcare data, for the past almost 2 decades now. And today's topic is common data models to improve Canadian healthcare, right? And it really digs into sharing data without sharing data. So what's the objective? It's really to discuss the benefits of establishing a common data model across a distributed research network of healthcare organizations. And this presentation will draw from our experience over the past 8 years working with the PCORNET and the Sentinel Research Network. So today's agenda, it's kind of full. There's going to be a background. We're going to talk what's a distributed research network, what's a common data model, the types of data. what's the workflow of a DRN after the establishment of the CDM, and reusable query tool, what type of study can we do with the common data model and the DRN, and at the end there's going to be questions and answers. So what's the problem? Well, the problem is really that, we have hospitals that are actually, all over Canada, right? And many of these institutions have access to a limited amount of data for analysis. And then most of the time, these data are just those data that you collect in-house for smaller organization. So this, after you do all the inclusions, exclusion, and filtering, you end up with very small sample size, low variability of your local data. And within your own organization, it becomes impossible to actually go ahead and create a study because of these limitations. Also, organizations also have a limited number of analytical resources on site, like programmers, analysts, data analysts, and all that. So at the end of the day, well, the organization, in order to do valuable studies, they need to have access to more data or combine their data with others. So this actually points to the collaboration scheme, right? Why don't we just pool our data together and have more patients and more years of follow-up to draw upon, right? So that's the ideal solution, right? Because most hospitals and organizations, they share the same common research questions from across the country, the same interest, and most importantly, they share the willingness to collaborate. Investigators want to collaborate. They want to share their data with Vancouver from Halifax. And like we've seen in the previous slide, the ideal would be to pull all the data into one central location for analyses. However, as most of you know, this is quite impossible to do. Data governance, security, internal policy often or always forbid sharing of patient-level data. And here the key term is really patient-level data. And also, let's say we could do a big pool of data, then we would need to have a multi-user access to a central location with permissions and all that, making sure data is not getting downloaded and whatnot. So this is a huge stumbling block, right, to performing high quality and powerful studies. So collaboration is not the simple collaboration is not an option for those reasons, and plus many other reasons, of course. So now we're going to talk about sharing data without sharing data, or how to pull data without pulling data. So to circumvent the no sharing of patient-level data, right? Many distributed research networks have been created in the last years, right? And what is a DRN? The DRN, or the Distributed Research Network, is really an infrastructure that is created to facilitate a multi-site observational and interventional research across participating organizations while minimizing the transfer of individual level data outside the system where care is received. So it's a network of people that are going to collaborate on studies. They're going to pool their data. They're going to share their data, but the data will never leave the site, the patient level data. So here are two big examples of networks that actually are still in production and really thriving right now. There's the Sentinel Initiative, which we've been, Eric and I, involved since 2008, since it was created at the Mini Sentinel. And also there's the PCORNET network, which is a more of an EHR kind of a network. For example, the Sentinel Initiative now have 21 data partner, and PCORNET has 80-something data partner in their network, sharing data without sharing data. So other example of network, there's a list here, maybe some of you know the HMO Research Network, which is like the mother of all research networks of these types. So let's go back to our problem, sharing data without sharing data. How do we do that? Well, You know, to set up the background for sharing data without sharing data, we know that each organization have their data organized and maintained differently. We all have our IT departments. We all have our different policies and system, Oracle, flat file, SAS files, Excel, right? And that alone makes it very difficult to collaborate and pull data, right? So the current practice, if we want to do like a network-wise, is that every hospital, every organization will actually perform their own local study in their framework, in their support data support infrastructure, right? And then they will have their own result, and then they will share their partial result to the network, right? Of course, this leads to an increase in development time and cost, and also potential for methodological inconsistencies, because if 80 hospitals are participating, you can get 80 different type of ways of interpreting a protocol, right? So then the simple yet very powerful idea is that what if all organizations organized and map their local data in the same way, right? On the same infrastructure, right? Then the same program, yeah, could be executed against each source of data individually, and the output from that program would also be in the same format because it's out of the same program. So in order to make that possible, right, the cornerstone of any distributed research network is the establishment, maintenance, and policing of a common data model. So a common data model is just a way of organizing data into a standard structure, right? So each institution in their hospital or in their university, they actually take their raw data and they map it or transform it into the local CDM, into the CDM specification, right? So you don't need to touch the raw data. The raw data remains untouched. You just remap this data, and usually, right, one could argue, well, I'm just copying the data. So if I have big data, it's just twice the big data. Well, usually experience show that only a very small subset of the locally maintained data is actually mapped or transformed into the CDM, right? And that CDM that you've mapped your data into actually stays at your site, will never leave your site, right? So you have like a minuscule copy in a standard format at each site, so everybody knows that, you know, you have that variable, you have that table, and if I write a program, you'll be able to run that program because everything has been, you know, standardized, right? So the CDMs in all the networks that I've showed, especially in the Sentinel network and the PCORNET network, I've really transformed the stumbling block of data privacy into a stepping stone, because it actually extends the reach to more data for organization or investigators in a very quick and efficient way, right? So the CDM, when it's combined to the DRN, has really limitless possibility. Right now in the United States, there's a huge momentum on CDMs and distributed research network, or DRNs, right? So the timing right now for us Canadian is ideal to actually, you know, piggyback on their experience and on their evolution, right? So without further ado, let's take a look at the PCORNET CDM. What is a CDM really? What does it look like? So the PCORNET data model, this is version 3.1, and we're already pushing version 4.0 soon, right? So it's actually a set of table with a limited number of variables within each of these tables, right? So for example, the demographic will have that. It can, this is the PCORNET. So there's a patient identifier, birth date, birth time, sex, gender, race, and other that any other type of demographic data you would like included in there, you can put in your own common data model. And then there's the dark green portion. This is really for on the PCORNET CDM. It's really the variable related to claims data that are quite specific to claims data, which is pharmacy dispensing and also healthcare enrollment. The next one is vitals, condition, and patient reported outcomes. So this is really what gets captured at the site. So as you see, we won't go through all of these, all of the specifics of the model, but this is the model that more than 80 organizations in the United States have set into place, mapped from their local data into this common data model. So when we run a study or we want to run a query, we have access to 80 chunks of data that are locally maintained at the site, which will never leave the site. So this is really the cornerstone of any distributed research network. What are the types of data that we can include in a CDM? Well, the answer is really any type of data. It can be cost data, it can be clinical trial data, claims data, EHR data, prescription surveys, PROs, adverse event data. It can be any type of data, right? It just needs to get mapped and documented that we're going to create this cost table. So we need to know what is the cost of an encounter, for example, or cost of a dispensing. We can create a cost table if we wanted to do a distributed cost study, for example, right? So any type of data. Typically, these are the data that were actually mapped into either or the PCORNET or the Sentinel CDM. So now that we have a common data model, every organization has their own raw data, right, in their format, in the way that the data warehousing is operating, right? They create an ETL, which is extract, transform, and load, into the CDM, which they keep at the site. So I'm ready, I have my CDM, hospital C say, I'm ready, I have my CDM, and so forth. So what then happens in order to use the CDM or use the distributed research network, there's a coordinating center, which can be any of the hospital, right, or an investigator that will actually write a program, right, in the decided kind of support for the data, right, to do the query or do the study, right? So they will write one program on the CD that will be set to be executed on the common data model, right? So this program will be packaged and sent to every data partner or participating organization. Once they receive this package, what do the partners need to do? Well, they need to do only 5 simple steps, right? They say who they are, where's my CDM located, and where's the 3 files, the structure that I'd unzipped. And then they execute the program. No further action required in order to execute, because we've agreed on the data, we've agreed on the data structure, we tested the data structure, we tested the data integrity, and now we're able to actually run requests. So this type of 5 steps, right now it's in SaaS program, where it can be in R, it can be in Apache Spark, it can be in any type of support, but it's a very simple. So when the site receives, they just change the path, they write their name, and they execute. When it's executed, as you see here, there's a folder called to send, right? So the to send typically is a folder, right, where data sets or output files are actually never containing any spatial. They're just kind of clever aggregates or frequencies or means and distributions that are actually outputted to the to send folder. So once the program successfully executed at each of the hospitals or each of the sites on their local CDM, they just zip the to send folder and send it back to the coordinating center, which the coordinating center, again, the coordinating center can be an hospital or can be outside of the hospital as well. So they pull and they do the report or start even writing on the manuscript already, right, to do the formal analyses. So this is how a DRN works within the CDM. So one program sent out to every site. They change their labels and they write their names, right? And they execute. That's it. It's as simple as that. And it's proven very, very, very useful over the past 8 years in both the networks and that we've been involved in the United States. So what are the types of distributed programs that we can actually run against the network? Well, the first one is the quality assessment program. This is a program that is written to check every participating organization or hospital's CDM, right? If, what are the min max values for key variables, what are the formats, right? If we expect pet ID to be character, is it numeric? So it's a series of flag that actually will go ahead and to quantify and give a quality check to your data. The second is a rapid querying. So when you do your ETL, typically people will do kind of standard frequency, what is how many unique users do we have with this diagnosis or this procedure, and it's a small table that is actually accessible to everyone in the network. The third bullet, which I believe is the most useful, is the reusable query tool, or how we call them, modular programs, right? That is, they're actually set up to run against the CDM, but they've been parameterized such a way that to use them, you don't have to write a single line of code. So the code will be closed, right? And we just change the input of the program. And as you'll see, we're going to have examples of reusable query programs that actually been used for many years with Sentinel, right? That you can actually do some pretty useful analyses within the day, right? Or the week. So it's not 4 to 6 weeks implementation, it's really within the week. And also the last bullet, it's ad hoc programming. So if you have a protocol base that you want to use the CDM of every organization, well, you will write a distributed program that will do the type of analysis you're interested in, and then it can be run against the network. So reusable tools. So again, the main advantage of a reusable tool, right, is to rapidly execute, queries or even studies, right? You just change the parameters. And this modular program, right, is just a suite of code that is designed to do this framework of study. So if you want to study diabetes with AMI, or diabetes and hospital readmission, or the impact on this comorbidity on time to discharge, the same modular program always can be used. So there's no reprogramming at all. And of course, it means future development cost reduction. So we're going to go with a quick example of a publicly available. Here's the link if you want to download the program, right? It's called Modular Program 3. It's really an exposure outcome modular program set to run on a CDM. So typically, this program has been, really the workhorse of the Sentinel networks for many years. Programming has been closed for quite a while, and it's still in use, right? Because it's only the inputs that will change, the input file. No programming required, right? And it, again, because you can change the parameters or the input file, list of code, definition, inclusion, exclusion, criteria at will, there's really an infinity of settings or HOIs that actually can be studied using the modular program. So here's the design of modular program. So you have an index date. Here's kind of a community acquired pneumonia kind of setup, right? So you get an hospital admission. I want to make sure that patient did not took any antibiotics in the past 183 days. No history of pneumonia, no history of hospitalization, because we're interested in community acquired pneumonia, right? And then they get hospitalized, right? And the follow-up period is admission to discharge, and the event date is an ICU admission within the hospital. So this is kind of the community-acquired pneumonia. So you really have a lot of flexibility on every parameters of your study. So if you're interested in knowing how it was used, right? And I'm going to go through an example which would run from these two public presentations that you can actually go ahead and download if you're interested into knowing how can I use that? What is this? How can I use this with a CDM structure in a distributed research network? These are the two great presentations that actually talks about the early years of the mini Sentinel pilot, because before becoming Sentinel, it was the mini Sentinel pilot, a 5-year pilot. So here's a quick example. On July 4th, there's a New York Times article that comes out that links a smoking cessation drug to cardiac outcomes. The day after, FDA say, I want to query. And the next day, right, they say they provide the final specs of what they want to study, how do they define the cardiac outcome event. 2 hours later, the distributed MP3, the Modular Program 3, is distributed to 17 data partners, right? I think it was more than 25 million live to reach to, right? And 2 days later, we have the report, right? What does the report? So before we go into the report, let's take exactly the same design structure that we had before for community-acquired pneumonia and set it up for this study. So what are the two drugs that we want to lose is bupropion and varenicline. We want incident use, so we want to make sure for, they were free of that drug in the 180 days prior. No cardiac history, right? So, and then as long as they were taking the drug, we would actually scan for cardiac event, and we would actually term the event a cardiac outcome. So in 2-3 days, right, using the Modular Program 3, we were able to actually go and identify million users of the drugs, of the two drugs, right, and find roughly 600 and something cardiac outcomes. And we even did, in the same run, a sensitivity analysis where we required patients to have in the vitals a prior known use of tobacco history, right? So it shaves down the sample size, but it's in the same request, in the same run, just in the input file, we just stack whatever we want to study. We had fewer events, of course. So then we can adjust for age, sex, age and sex, HS and L plan, right? In the Sentinel CDM, and to show that there were actually no increased risk of cardiac outcome when we compared the two drugs, right? So this was all done within 1 week from the New York Times on Monday, and on the Friday, FDA had their report. So it's very quick. Right? So that's a very great use of the reusable tools. Now, if we want to do protocol-based research, right, it's actually been used a lot of time. For example, here we actually went to ad hoc programming and decided that we wanted to see if there's a angioedema, right? So that was, wanted to be queried against these type of drugs, right? Another ongoing study with the PCORNET network right now that we are involved in. Actually, you can see here at the bottom, they're registered under clinicaltrial.gov, so this is all of public domain. Right, we want to use the 80 plus data partners, right, to see what happens after bariatric surgery, right? With respect to change in weight, because we have access to vitals from 80 different organizations, rates of remissions, and risk of major events, right? And these studies are done with very univariate and also multivariate type of analyses, right? Very complicated. Again, keep in mind, without even seeing one patient level data, ever, right? Another example right now is the short and long-term effects of antibiotic on childhood growth. So again, the link is down for the details and specifics. But again, it's really to measure the BMI, right, 5 and 10, and growth trajectory out of 5 years of age for patients that have used antibiotics in the early years of their lives, right? So this is exactly, and it's currently ongoing. Actually, we're wrapping it up this year, these studies, because there was a lot of different sub-studies that we're actually conducting using the PCORNET network. So again, pooling data without pooling data, or sharing data without sharing data. So we're running this one study on 80 sites, right? On up to 80 sites, because some sites did not have any youth, so they were left out, of course. And we get this very strong, very powerful study, using these data. So what can we do as a study? I keep using the word study, but without seeing the patient level data, because if I want to run a regression, for example, I would need to pool all the data at one central location and run the regression on the covariates. So that is the typical way of seeing it. But in a distributed regression, right, you will need to send a package, right? And it's all public domain. The algorithms are out there ready to use and download, right, on the Sentinel website, or probably soon on the PCORNET website, so that you can run the same regression where you send the package to every site, right? They run it against their CDM and send aggregate tables, right? And with clever recomputing, you would get exactly the same estimate, exactly the same standard errors, as if you were sitting on the entire 80 site data, right? So you can do, well, of course, descriptive statistic, incidence rate. Well, you can do a distributed linear regression just as if you were sitting on the actual patient level data. Same with logistics, same with Cox, same with Poisson. And right now there are new methods that we actually developing to show that you don't need to have the patient level data to run these sophisticated analyses, right? So here's a paper that was published in 2013 on the angioedema study that Eric and I worked on, that actually proved that if you have access to the patient level data and just the CDM on-site data, you get exactly the same answer, not an estimate, a same exact answer as if you were sitting on the patient level data. So it's really cool. Here's another study right here that is actually ongoing, is that we're actually developing new methods, which now are their term privacy-preserving methods, right? So that you actually run data, you run analyses without seeing the patient level data. You just see aggregate tables and you get exactly the same answer. So this PCORI funded project is actually to develop method. And the aim 3, which we are at right now, is create freely available analytical tools, right? So that all these methods will actually be downloadable and usable in many supports. So, and here's the two links at the end. So, lessons learned. And this is a great quote for the lesson learned, right? Is start small and act now, but dream big, right? It's really the best quote. When you want to actually go ahead to set up a CDM in a network of hospital, let's say across Canada, right? Start now. Don't over specify on the things you might never need, right? Start simple and then build from there, and when you miss a variable, add it to the next version of the CDM, right? Because over specification will just, people will lose interest. And even in the very early phases of a pilot or the setup of the CDM, very useful information can already be used from the smaller network. So if we use the Sentinel initiative as an example, which actually the Sentinel initiative was preceded by the mini Sentinel pilot for 5 years, right? So you start with a few collaborating hospitals, 3 or 5, right? you agree on a limited number of tables that you want to set up in your CDM, because right now you're really more interested in the process than in actual network. But as you see, if you get these 6 tables set up, there's a lot of answers you can already answer, using the CDM. So each hospital will actually create a small table called demographics with a handful of these variables. Most hospitals capture systematically vitals data. You can do this, and also you can, abstract, the from any hospital encounter, what were the diagnoses and what were the procedures and what was the prescribing within the hospital. So you can really focus on a small number of table with a small number of variables with, a handful of participating hospitals, and get your network up and running very quickly. And when you'll see when it unlocks its full potential, even at 3 or 4, 5 sites, you already see the advantages and the benefits. Also, when you create your CDM, always think on how am I going to test this variable when I'm going to add a new partner in the network, right? Oh, yes, I have diagnosis, and they're all ICD-9 codes or ICD-10 codes or SNOMED codes. And if you do a proc freak on them, you find other codes that are badly typed, right? So this CDM would be rejected. They would need to correct that. And once they passed all the quality assessment package, again, the package is done. There is a very good example of this package downloadable from the Sentinel website for free. So once you pass all your flags, you're in, right? It's very simple to use. So, and also keep in mind that your data model can always grow, right? This is a great lesson learned in the early years of Sentinel. There were too many variables. Some were chopped because they were never used, right? And they were just taking space. But if you do forget a variable and later you need that variable, just add it, right? So by adding, like creating a building block framework, you can always retrofit, right? You can always say, hey, I got this program. It used to work on CDM V1, but make sure if you go to V2, that V1 is always supported, right? So after the CDM is specified, start developing, running very simple head counts, simple correlations, right? Queries to actually tame the beast, right? And set up all the process of sharing and receiving aggregate table back. Like we've said, don't overspecify, think incremental, and lessons learned, go on the Mini Sentinel, you piggyback on the Mini Sentinel and PCORNET experience, which are all laid out online, ready for you to download documentation, CDM, QA package. And for Sentinel, all of their tools is in SaaS. They're ready for download, right? Continuous enrollment, stockpiling, exposure event outcomes program. They're all there for you to download and use freely. So these are some useful references. I know there's a children's hospital, which is called the PedNet network from PCORI. There's a link there, and the different links that we've discussed throughout the presentation, right? So now we're at I'm sure that people, I know there's a lot of information, but the purpose of the presentation was really to get you guys curious about it, and also to give you, to let you know that everything that's been done over the past 8 years is available at 2 main locations and free to download and to use, right? So you don't need to reinvent the wheel. You can just start driving very quickly. Thank you.
All right. Thank you for that presentation. And certainly, if anyone did get, it was a great presentation. I think it really brought some of this really highly technical information to a little bit lower level. But if anybody does have any questions for clarification on any of that, I'm sure please put those in. We do have some questions. So one of the first questions that came up was about someone obviously familiar with some of the space. She's asking if this or how this process or some of the infrastructure you're using compares to Data Shield, if you're familiar with Data Shield, or is this in any way an implementation of Data Shield?
I know of Data Shield, not their specifics, but it's really, the difference is that if I go to this slide here, right? It's the transportation of the program and the data returning back that is very similar, right? But here, it's either through a portal that you actually upload a program package that participating hospital will download, and once they're agreed, they will upload on the portal the data. So there's no way for to directly access hospital to a kind of a setup. So it's similar, but it's very different because you keep the control on who accesses and how it accesses.
Okay. And if Hannah, if you need a follow-up question, please don't hesitate to put up in a follow-up, and we'll certainly come back to that. The next question, there was a number of questions around sort of the issue, the topic of collaboration, and how you come to consensus on some of these pieces. So, for example, are specific indicators used to build a CDM at each center, and who decides on the indicators? Do all the sites that participate in the CDM agree upon collecting certain defined indicators? And how does that, maybe just a little more information about how that collaboration or how those decisions are made?
Well, it really works for Sentinel and PCORNET, it really worked with work groups, right? So like I was saying, if you were to set up a pilot, you would start with a few organization that would say, hey, I have these data, I have these data, I have these data, right? So if you want, and people say, if you take the PCORNET as a starting point, right, you can say, is this something that can be useful in the near future? Is this something in the near? So you drop down, to a very limited number of tables, right? And it's just the first participating organizations or investigators interested in using the network that will say, hey, my first query will just, do like a weight cohort kind of approach, which is, I'm going to go in my children and, I just want to know what is the evolution of BMI or height and weight through time, for example, right? It's a very simple query. So for this, what do I need? And then you can already set up the CDM, right? In terms of that. So it's really investigators based and sitting around the table and say, what is the first query or study that we want to use, and create a CDM for that. The next study, well, you might be missing a piece of information. You just add it to the CDM. So whatever you've done for that first one will actually work. So this is how PCORNET and Sentinel actually grew their model. So if you go to the CDM network, the website on the CDM page, you'll see that V4 of the CDM of PCORNET is actually adding a lot of new variables, right, that are actually needed for the next round of studies that people are interested in. But it's really investigators that sit down and say, what are the main information I want in my V1 of the CDM, and what do I want to use with them? So it's really sitting around a table and selecting what variables we can and cannot do. So if we have 3 organizations that do not capture vitals, well, there's not going to be, these data partners will not, join in on any vital-based study, for example. So they will be left out of these studies. But if they have diagnoses and procedures and we don't need vitals, then they can actually participate in these studies. So it's really your data limitations and how you intend to use your data that it actually gets decided. So, and Sentinel actually, and PCORNET actually, use different formats for some variables, some different SOPs for some mapping and transformation. And what's online, it's really what has proven to be the most useful. And this is where I say, we can actually pick it up where they left off and Canadianize it to our best knowledge. So that's how it gets decided. It's really investigators and data availability for the first participating partners.
Right? So if you had 10 sites participating, for example, across the network, and one of them did not collect a particular variable, does that impact the system in any way? Like if not every
Absolutely. Well, no, it doesn't, because an inventory is actually set at the coordinating center. So each time you need a variable or a table, right? If we say at a table level, right, and I need vitals to conduct this study, sites without vital could not be used, but they will still create their own CDM, because maybe there's a diagnosis procedure frequency study that wants to be established, and they can actually pull their data into that study. So even if they're missing a variable, the coding guidelines say create that variable empty, right? For example, death and cause of death. Some organizations do not capture that, right? But these tables in the CDM are actually created empty, because the standard program, if it needs to check if in these tables, right, it will bomb if the tables or the variables don't exist. So these tables in the CDM are actually created empty just for the program to run, right? Let's say you want to do like a stratification on BMI, but the overall results is also of importance. So you're going to run the modular program, and whenever it's going to go and try to do the vital portion of the program, it will just skip to the next one, but it will not bomb saying table does not exist, variable does not exist. So the SOP so everybody will have exactly the same number of data files and same number of variable, some of which can be empty, but the modular program will actually account for that. We call that defensive coding when we develop modular program, right, to account for that, right?
Okay. So, another question that came in was related to disclosure risk, and how is disclosure risk assessed? So for example, if you have small cell sizes, are they assessed at the point of what you mentioned as the to send point from each institution? Is that happening at the coordinating center?
In the PCORNET network, the standard operating procedures exactly to this point is that if you remember this slide here, in PCORNET, there is an extra parameter called threshold, right? This is your low cell count threshold that you do not want any numbers to be outputted if you're below that threshold, right? Each organization have their own threshold. So by setting it up in the header of the program, the coordinating center has no real way to know what is this, because at the end of the program, all the aggregates, right, if it's an aggregate that is deemed a low cell count, right, will be set to missing, right? It's a special type of missing, so that we know it's been masked. And also, if there are some SAS people in there, we also have an algorithm that after your program executed, will go through your logs, right, and make sure that if there's a data set with a certain below the threshold observation count, right, it will actually mask it, right? It will say this data set has below threshold observation, right? But we don't know what the threshold, and it's not outputted in the logs. So the threshold is actually it's actually proprietary of the site, but the logs and the tables returned, they're actually masked, especially for frequencies and things like that. So if you're studying hemophilia, for example, right, and you're stratifying by sex, so it's something that is kind of not really HIPAA compliant, because there's so few, females with hemophilia. So you would actually like the disclosure. So each site set their own threshold. The logs are actually rewritten to mask based on the threshold set at runtime. It's really set at runtime. The coordinating center doesn't know of the threshold of anyone. That's how it's actually being currently handled in all of the PCORNET programs that are being sent out to the network.
Okay.
Great question, by the way.
Yeah. All right. Thank you. All right. So that
and
is
one last point also. Any PATs, right? Any PATs logs are also scanned to delete any PATs, right? Because PATs can provide some structure information, and some IT departments say it's a breach in security. So we have a piece of code in PCORNET that actually just goes through the log and removes the paths in the logs to make sure that they're not publicly available, right? That my data was stored at, I don't know, Moyneur desktop, results to delete, there's no way for that also to know.
All right. So that is, we do have just one more quick question here, but just my chance to remind the audience, if you do have any questions, we do have a couple more minutes left. If you do, if you're in the process of typing something in or thinking about something, try and get it in as quickly as you can. The last question that came in was just about where can you mentioned that all of these tools from both Sentinel and PCORNET are available. I put the links for sentinelinitiative.org and pcornet.org in the chat box. Is that where people would find the tools that they could download if they wanted to start?
Well, actually, if you go, I don't know if people can still see my screen, Doug, but yep, if you go, okay, so the last slide right here, there is hold on, let me go back. Here is the Sentinel, actually the link to the surveillance tool, right, to download, right? Unfortunately, PCORNET does not share their code yet, but you can write to them, and well, all the PCORNET codes were based on the Sentinel codes because it's both projects are handled by the Harvard Pilgrim Healthcare Institute, so and they share the codes. So all the codes and the tools for the Sentinel CDM, which is almost equal to the PCORNET CDM, can be downloaded there. And also on the presentation, PMP3 has been retired, right? But it's still available for downloading. All the package, the documentation, I've put the exact link to download this. And if you go to the Sentinel, actually the Sentinel web page, for example, right? It's organized here, right? So you get here everything related to the common data model, right? And you have the routine and the software toolkits. Everything is there. Even the studies that they ran last year and the year before are all there with the results actually shared because it's funded by the public domain, so they have to make everything public. So if we go here you see another depiction of how the network actually operates within data partners, right? So, and if you go down here, right, so you see that the data QA package, right? Or this is the report. There you go. Data quality review. If you go here, then you get a zip with the SAS programs inside of it, right? And you can just go ahead and use the program, right, to actually run your. So you'll recognize a heading that was similar to that you've seen in the presentation. Just changed it a little. So everything is there and ready to use, right? The CDM, the QA package is there. You get here, if you go in the routine tool, one note, the level 1 modular program queries, this is really descriptive analytics and cohort. Level 2 is high dimensional propensity score matching, survival analysis packages to run against a CDM, again, without seeing a patient level data. So those are the different, self-controlled, you get perform propensity score and matching and run your analysis on matched data at each site. And then when you pull that, all the analysis, you also get the summary program, right? So all the programs that are needed, once you run these packages, how do you combine them into one set of results as if you were sitting on the entire data, right? All the programs are there as well for you to download, right? Some software toolkits. So everything is there to download free. Right now, the support of Sentinel and PCORNET is in SAS, but everything is there for you to download and to look into.
All right, that's great. And for everyone in the audience, the presentation that Eric just used, the slide deck, is in the handout section. It'll be available on the Knowledge Exchange Network as well. So all of those links you can get. You don't have to sort of try and go back and type those long links in. They'll be in the presentation. Download and go straight to those there.
And they point you to where it's related, but feel free to browse and get lost in the plethora of information that Sentinel have put. They've actually worked a lot. And also, if you want to look how to implement a network, the Brookings presentation, there you go. These are the two links to the PDFs, right? It's how it was set up in the Mini. So how the variables got selected, how it was used, how many times it was used, resources available and whatnot, what got considered, not considered. So you get these two great PDFs that you can actually download and while eating a sandwich, just go through and learn 5, 6 years of work into these presentations. They're actually very useful.
Yeah, all right. We did have one last question came in from Brett, and I'm not sure if you're going to know what he means by this or not. I know I certainly don't, as it's gone beyond my level of expertise with this. But he's just asking, will there be support for R at some point? If you know what R is.
I know what R is, and that's why I purposely, and the question, unfortunately for Sentinel and PCORNET, the answer is no. Because it's everything has been built in SAS, and for the participating organization in PCORNET and Sentinel, SAS is the requirement. But I've put on purpose R here because if we are to set a network, we can do it in whatever we want, right? Just as deciding what CDM tables we want, R is gaining a lot, of support. And what we've done is all doable in R and Stata, in Apache Spark. We could also do it in Amazon AWS. We can do it anywhere. Right now, Sentinel and PCORNET have chosen SAS. So, and I've never heard of them wanting to migrate anywhere. At some point, there were some R code, but we were asked to reprogram it in SAS. So,
all right.
But there is support. Well, Statlog can support also in R. But the Sentinel network or downloading the algorithm, downloading R files, it's not in the plans that I know of. Right?
All right, sounds good. And I think with that, we'll wrap it up. Is there any, just give you one last chance, any key messages or closing messages you'd like to leave the audience with before we wrap up, just to close it off?
Yeah, yes, it's a very simple yet powerful idea, the CDM, right? And like I've put, if you want to set it up, don't overspecify, start small and build up. And even very small, and this is the biggest lesson learned from the mini Sentinel pilot. They started small, and it has proven, even that's very small. So this is what you see from the Varencline episode, right? Which was in 2011. It was 2 years after. It proven very useful, and it actually grew from there because they said, hey, on Monday I have a question, on Friday I got the answer using 20+ million lives, right? So I've just proven my worth. So don't overspecify.
All right, sounds good.
It's the greatest trap.
All right. Well, thank you very much. A great presentation. Again, it really took us some high-level data conversation, and I think it brought, at least let people see how it can be used on the ground in the healthcare system to make real decisions and make changes in the system. So, thank you very much for that to both Erick Moyneur and Eric Gavel. We didn't hear in the background too much, but it was great to have you both here with us. We do our webinars every Wednesday at 11 a.m. Eastern Time, as most of you know, and it's always great when you can watch live, as your questions and comments really enrich the discussion. But when you can't watch live, of course, we do record these sessions and make them available after the fact on the Knowledge Exchange Network, which you can find at ken.cafc.org. That's ken.cafc.org. Our next webinar next week is on February 7th. I can't believe it's February already, but we'll have another data-focused session, and we're going to be hearing about the information age and improving and transforming the Canadian health ecosystem. And in this session, we're going to hear from our colleagues that developed the Pediatric Rehabilitation Reporting System, and they're going to give us some insight from the inaugural report that they just produced this past year, which if you're at the CAFC annual conference, they released that initial report there. And they will lead a discussion on the challenges and success that were overcome when implementing a national data reporting system in the rehabilitation sector. And then following that on February 14th, I wish I could say it was a very special Valentine's Day presentation, but I don't know as it's quite tied to Valentine's Day, but we're going to ask the questions, what have we tried and what works? A Canadian environmental scan of organizational supports for moving evidence into action in pediatrics. And just to talk about the significant challenges in moving evidence into action or evidence to practice in healthcare. And we're going to hear from Stephanie Glegg from Sunny Hill Health Center in Vancouver, who's been doing research in the area of knowledge translation for many years. And she's going to share with us an overview of what we've tried and what works in moving evidence to practice. So that'll be a great and I believe very practical session for anyone who's looking to change practice in their organizations. So some great stuff coming up in the next couple of weeks, and hopefully we'll see you back here next week. Bye, everyone.